Okay, welcome to the Craniotomy podcast, where we delve into issues related to the brain with those who are on the front lines of neuromodulation and neuropsychiatry. I'm your host, Muhammad Nasser, here in Tucson, Arizona. With us, as usual, our neurosurgeon, Dr. DavidDarrow. Hi, David. And
Hello.
our psychiatrist, Dr. AlexanderHerman. Hi, Alex.
Hello.
I'm more than happy to welcome our guest for the day, Dr. Don Nixdorf. Professor and Director of the Division of TMD and Orofacial Pain at the University of Minnesota. Hi, Dr. Nixdorf.
Hi there. Thank you for having me.
Yeah, thank you for being with us. Would love to hear more about your work and what you do.
So I'm a dentist, and my area of interest is the diagnosis and treatment of patients that have facial pain. So typically patients that have TMD, which is a musculoskeletal pain of the jaws, muscles, mastication, as well as nerve pains in the face, and headache disorders are kind of the three big ones. And so I look at diagnosing patients and helping manage them from a non-surgical approach. And so that's kind of what I do also from an education perspective, and research-wise is the same thing. So it's kind of focused on that.
And that's Don's way of telling us that he's Canadian because he treats those skeletal muscles.
Yeah, I can't get rid of that one.
Has any of your work overlapped with the work that David and Alex are doing?
Yeah. So what's really interesting is from the nerve pain aspects, there is one condition, trigeminal neuralgia, that we both treat. And so neurosurgeons like DavidDarrow surgically treat patients that have that pain. And what is more interesting is now in the age of neuromodulation with less invasive types of approaches. And so their lab is looking at doing is how does changing the activity of some of the nerves change how patients perceive and experience pain is really exciting. So there's a lot of crossover there. I'm looking forward to working more with them.
Yeah, I think one of the interesting things about this sort of intersection between pain and some of the work we do focused more on the prefrontal cortex is something that comes up quite often in your practice, which is trying to tease apart and understand the causal relationships between pain as a form of sensation and really higher order cognition or mood and the interaction there.
Definitely. What is common in our practice is if patients have chronic pain for a while, they'll almost always pick up mood disorders like depression, anxiety, and then sleep disturbances. And I bet Alex can talk a little bit more on it, but we have the belief system that doesn't matter which of the three you get first, if you have it long enough, you pick up the other two. So if you have a lot of mood disorders, you'll have dysregulated sleep, pain hypersensitivity kind of comes along with it. So it seems to, what I tell my patients is it's like three faces of the same head. If you see one, the others are just around the corner.
I think that's very well put. And, in depression, there's a lot of debate over whether or not sleep disturbances precede the depression or vice versa, and if there's causality. And maybe for some people it's one, and for some people it's the other. Or maybe that's even the wrong way of thinking about it. They're just two sort of, emergent phenomenon of some underlying system that's affected. And I definitely see how pain could just fit right into that same kind of conceptual model. So many of our patients have chronic pain. It makes total sense to me. Of course, I guess as you probably see, you don't see patients with depression without pain because you're seeing the pain patients, obviously. But when you take a history, do you get a sense of the time course being different for different people in terms of when one or the other emerged?
Yes. So sometimes the history is pretty clear that they pick up a pain problem first, and then the mood and stuff comes later. And an example of that would be someone that has migraine and experience it in a young age, such as teenagehood or their 20s. And then it evolves into a chronic version of migraine where it's coming more often. Those are the ones where you clearly can pick up a pain first, mood disorder second, sleep kind of third. But you'll also see another phenotype, if you will, of someone who's had dysregulated mood for a long period of their life will pick up, say, a jaw injury and then have a later onset TMD. There was a landmark study by a luminary in our field who recently passed away. His name is Bill Maxer. And it was a prospective observational study to look at new onset TMD. And so he looked at things like mood, sleep degradation, and autonomic regulation. And so he followed patients that did not have TMD over the course of years to see what the new onset was. And what it was is psychosocial distress, sleep disturbance, small injury of their jaw, could be as small as repetitive stress strain activities, was then the new onset of TMD within that study.
Don, you said in the introduction, you're looking into how patients perceive pain, right? I'm interested to hear more about that. Like, what trends are you seeing? What issues are you seeing with perception versus what is the opposite on that scale? Is it perception of pain versus actual physical pain?
One of the things I think people need to realize is, as of now, we don't really have a biomarker or some sort of indirect way of measuring somebody's pain.
Mm-hmm.
So it is a subjective measure, just like something like the level of like love or other types of internally experienced phenomenon. But we don't get to actually sense or feel it, and we only get to measure it or understand it through the interpretations of the patient.
Mm-hmm.
And how I view that is there is a huge variety of pain sensitivity. There was a really interesting study that looked at the genetics. And what they did is they took one type of pain stimuli, I think it was something like 49 degrees Celsius, and they applied it just to the inside of the arm or something like that, just a standard way of giving pain. And they saw 500 people off the street, so healthy controls. And in the standard approach, then they asked them on a 0 to 100 scale, what was their pain intensity? And they got almost a linear line. Someone saying nothing to someone saying 100 and everything in between. And so what it really tells us is that, at least in that simplistic way, is that you get this huge variability about how people sense and express. They're kind of stuck together.
Mm-hmm.
And some of the times in our field, we have patients that they're worried a little bit because it does come with mood disorders. They're thinking, am I crazy? Am I making this up? No one can see what I'm experiencing. They look, say, in my mouth, there's nothing wrong with my teeth. There's nothing wrong with the structures. They have this underlying angst sometimes that, am I going crazy? And the answer that I always tell them, I jokingly say, well, yeah, it's all in your head just because your brain's in your head and the nerves that we're talking about are in your head. But to validate that process that they're going through, I think is a really important thing, and that there is this large spectrum of how people sense and feel their world.
Mm-hmm.
I think it's been long acknowledged that some of the challenges that we face in trying to study people's pain is that we know that it's relative, and that makes it very difficult to essentially do group statistics or compare across people. And it's one of the most challenging aspects of pain. Essentially, every clinic I have patients with pain. You're an expert in this area of how this can be described and quantified. But at the end of the day, in my mind, most of the time, the actual rating doesn't matter too much. It's really about the disability that it brings and how it affects someone's life and how they think about it more than the actual scale, because the vast majority of the time, I do see a trend where, over time, patients do refine their own way of rating their pain. They really understand what 10 out of 10 is in their world. And oftentimes in the early course of pain, it's quite variable how people report it, or it's just maximal, 10 out of 10 or 20 out of 10. That's really how most patients express it. It's more of a language thing, I think, than a quantitative thing.
The thinking that we have in the pain field is that when people are younger in their life, they don't have a lot of those other experiences to give a relative measure to it. And as people pick up more life experiences and painful events, they kind of refine. Do keep in mind, there's also when patients are asked to, say, give a pain intensity, which is what we often talk about in the clinic, is that patients are giving you more than just the intensity. They're giving you how much they're suffering and their impact in their life and the disability.
And that brings up a really, good point that you brought up earlier, is the sort of process of pain and the centralization of pain that we often see, and how, in many ways, I sort of think of it as almost an infection. With an ongoing infection, it sort of feeds into the rest of the system if it's not treated. And I think that's a big aspect of what pain research has learned over the last few decades is what does the longitudinal prognosis look like for a lot of patients with and without intervention, with and without care.
One of the areas that you and David are looking at is a very common one too, where patients will feel that they just don't have the mental horsepower, if you will, to be able to get some of their cognitive tasks done. So they feel like they're a little bit into a fog, or they're mentally hampered. That's a very common one that patients will kind of talk about when the pain is worse.
And that sort of cuts both ways with sort of treatment for pain, right? Because the medications that we commonly give for pain or neuropathic pain often affect cognition, very, very commonly. And then the other way, if you're in acute pain and ongoing pain, it's impossible. It's exhausting. It's absolutely exhausting to tend to the pain, to try to avoid triggers that could make the pain worse. That sort of fear avoidance and trying to mitigate any modulation of the pain that can make it worse. That's exhausting for a lot of patients.
And some of the patients that you get to know over the years, as you see them on medications that have the potential to have with the anticholinergic effects have been increased there, and they're aging, and so they're in their 60s, 70s, 80s, and they're getting some cognitive decline. And you're wondering, okay, is it aging? Is it drug side effects? What is it? And so you can see them really wrestling with that side of complications.
You're bringing up the possible psychological effect to such injuries and disabilities. Do you feel like the treatment has a holistic approach to a patient? Is the patient being looked at from different angles, not just the physical side of pain, but also what needs to be done to manage pain, to maybe live with it, to deal with the shame factor that possibly can impact others more, some more than others. So how do you feel about the approach to treatment, given how complicated the problem could be?
Yeah, so in my, to answer that question depends on the viewpoint of the provider that you're interacting with. I think there's two really ways that you'll see in today's society. You'll have a biomedical approach, and that's usually focused on nociception and pain itself. And then the other way is called the biopsychosocial, which actually the important aspect, it would be called psychological social biotype approach, probably more like it. And that's kind of getting at your question there, in that the psychological aspects of the affects a person. How I explain it to patients is what they feel and perceive is what's going on with themselves, is one aspect of how they as a person modulate or will color their experience of pain. And then it will be colored again as they will express it. And so through those types of ways, it will give it a different color or flavor, how it presents. And in my opinion, you cannot separate the mind and the body. The two are inexplicably linked. And so that's why the biopsychosocial is really the only true way from a chronic pain perspective that you'll be able to manage it. And so you need to always be looking at the person as well as the kind of the diagnosis of that. And so in our field, we have a diagnostic system where we broke it into two axes, where it has that kind of the nociceptive axis, which we call axis 1, and then we have the psychological social axis, what we call axis 2. And as you would imagine, the majority of the disability tracks with axis 2, which is psychology, sleep, and so forth.
And it's really interesting because that pairs very closely with psychiatry in a lot of ways.
So we in the TMD field stole that from psychiatry. Well, maybe we borrowed it.
We've since gotten rid of it, so these things go in like cycles. But
well, I think more so than anything, at least what Alex and I are trying to do is, instead of rotating the axes of how we're diagnosing things, try to bring it all together, because certainly all the psychological aspects have biological components. And the harder you look, the more you find. It's a very challenging problem because the dimensionality is quite large, but certainly we can start to pick away at it a little bit and make it, there's, from our perspective, things like, health psychology and doing cognitive behavioral therapy, that is just another form of neuromodulation. That just doesn't bill as well, but yeah, I mean, it's another form of neuromodulation. It's a lot. It has so many degrees of freedom that it's hard to parameterize. It's hard to optimize. And so it's very sort of user dependent. And these things are coming together quite nicely over the years, but we certainly recognize that as we're trying harder and harder to pull all these things together. And I think along those lines, we focused most recently on cognition and how these things interact and may play a role in cognition, because for a very specific reason, which is how pain affects the decisions that we make on a daily basis and monthly basis with our healthcare, with our life, because really a lot of the things that are challenging about pain care come down to those decisions.
We're, as a clinic, really focused on behavioral management, and so changing behaviors. So even though we're dentists, actually I had a husband of a patient today kind of say, this is starting to sound like a psychologist appointment. And so I laughed. I'm like, you're 100% correct. We're here in changing behaviors, and we know that pain has a negative affect to some of the behaviors. So it changes them, gets them kind of doing different things. And how do you then set the patient up for success in that process? That's not always easy.
Do you have patients from different cultural, ethnic backgrounds, and therefore, you're talking about decision making, changing habits, behavior control? How does that play out in the context of different cultures and backgrounds?
Generally, when we're using questionnaires, we will have them language culturally kind of tested, if you will. And then when we move to a different language, even something relatively similar culture, say right now in the process of translating some of our work into Swedish, culture's close. But now if you take it and move it more into Arabic, that might not be so similar. And the way we use words and understand the meaning and have that shared experience is different. And so in Minnesota, we have a population of Somali people, and we'll use interpreters. And I find it really difficult because they will use some words in a way that it's not logical to me. It doesn't make what I would call face validity on what they're experiencing. And now that I've seen a number of patients over the years, I kind of have a sense about when they're saying these things, they mean this cultural language equivalent to what my other patients would be saying. What I thought was interesting, just to kind of give you a little bit of background, is something like migraine prevalence. I did look at it years ago. I was interested in maybe having a career shift going that direction. And so I looked, okay, is the experience of migraine radically different in different populations? And what I found was, from the published research available at the time, not really. It was kind of very similar. I would gather that how they presented their migraine and that kind of stuff may be a little different. And it kind of comes to some of the folklore associated with migraine, because historically it was thought to be a rich woman's disease, if you will. And I think that's because at the time in the Western culture, those are the people that had the luxury to sit back and complain and not engage in life and complain about their headaches. Where if you were poor, you still had to go to work. You still had to get through your day. And no, you weren't complaining because you wanted to keep your job.
Very akin to this discussion about the challenges of communication is also the challenge of sometimes separating migraine from facial pain. And something that I don't think a lot of people know about, because migraines are extremely common. It's the second most prevalent type of chronic pain after back pain. And understanding, the context of the prevalence of migraine, and when we start to see facial pain patients, just last week I was seeing, patients where at least one patient that was able to tell me very explicitly the difference between her facial pain and her migraine. But oftentimes, these things sort of interact a lot. And I don't think a lot of people realize how much that's true. And there are some very specific anatomic reasons why that is true, right? The trigeminal nerve is sort of I was thinking about this. It's really the highest nerve closest to the brain that can still really have pain, more or less. There's vision, but visual threat is not really something that we consider to be painful.
And we also know when headache has been there for a long period of time, it doesn't respect the anatomical barriers. Start having it spread across the cranial nerves, including its own branches within the trigeminal. And we'll see that. So it's not uncommon for patients when they have a migraine attack. If you ask them, they'll say, "Yeah, my teeth on that side, my teeth become more sensitive."
So some people with migraine get ocular phenomena, right? And so are there ever any ocular phenomena with facial pain, or is that actually a division where one has a cortical component and the other doesn't?
The aura, I think it can happen with the headache. Sometimes it precedes it, sometimes at the same time, sometimes it comes without headache. And what we see with the variant that presents in the face is that it is much less common with some aura. It has prodrome, but not so much aura. And I think that helps in it being missed as well. Because when someone will get something like a change in sensation or visual sense change, that's usually a tip off to their providers that it's migraine.
At least for things like phasic pain, at least like tic, we think that is, as many have noticed over the past century, it's much more like a seizure in many cases because it's short, quick, whereas a lot of migraine or headache stuff is much more chronic, lasts, minutes to hours. It's very different. And I think that experience of it is quite different, phasic and acute sort of pains versus chronic pains. It changes a lot about how it's experienced. And I think the adaptation to it, at least trigeminal neuralgia used to be called suicide disease because you just cannot, the shocks are so random and you can never adapt to it. Even on a biological level, you can never adapt to it. So there's no hope on a cognitive level.
Don, talking about this 2-axis system, which I'm reflecting just back in my mind a little bit about what David was saying, is maybe just the wrong coordinate system for representing, pain. But if you only have nociceptive and then everything else, which is kind of what it sounded like to me.
Yep.
That means that the affective, the cognitive, these components get projected onto the everything else axis, the axis 2. Which to me, and obviously I'm naive about this field, but it strikes me as missing some of the granularity because, it occurs to me that maybe there should be additional axes, if you will, beyond those two. And I wonder, and so that makes me think a little bit about, what do we know, if anything, about what helps cognitive function in people with pain? And what do we know about what helps with mood? And is it different? If anything, is that a body of research that has been developed at all for, approaching decision-making deficits in pain? Or
So yes, there is a body of literature, and there are quite a number of people that are interested in it. It is not well studied. Your question about the access to having so many things dumped into it, if you will, is well known. And there has been, I guess this is about like 5 to 10 years ago, the American Pain Society advocated breaking that up, and they went to like a 5 or 6 axis. So really trying to get to
get right onto the DSM, just like you can't miss it.
And
we don't want to throw the baby out with the bathwater.
We want to look at all the different axes. I lauded, and the type of person I am, let's break it into all its little pieces so you can kind of keep it in. But the reality is the rest of the world is still on a one axis. The WHO and the International Association for the Study of Pain has a singular axis diagnosis. So even though us in dentistry, you can fault us for lumping it into a 2 axis, we're still light years ahead, which is kind of sad because, like you said, we're missing some of the important aspects that individual people experience, and it is important to them. And so by default, how we address that is we take extra time and talk with patients to try and get to understand that aspect of things. We haven't been able to take our practice and break it down into smaller algorithms that you can kind of ask and do things. You really have to get to know the person and understand what's important to them and why. And how I teach it to dental students is the dysfunction that is playing a role in perpetuating patients' pain can be everything from the kind of more cellular aspects of things, probably things like trigeminal neuralgia has some components underlying it, migraine. It can be behavioral, can be personal, can be social in their aspects of things. So you have to, as a clinician, screen for all of these different levels of where their dysfunction may be playing a role. And at the same time, not forgetting that they could have organic disease in some distribution of this that is perpetuating the pain as well. There's nothing that has to say that, yes, sure, you have neuropathic pain, but you still can have dental abscess too.
Has anyone ever tried like stimulants for, cognitive deficits in pain? Something like that? I mean,
yeah.
Yes.
Yes. Okay. Does it help at all? Is there any benefit?
The average person is using caffeine for that.
Yeah.
He was picking up his glass.
Yeah.
But we do see it from a medical side of things, and we'll see it generally from your colleagues when patients will be talking about cognitive, like it's usually associated with side effects. So they'll be using medications like Trigeminal and those type of drugs as stimulants. Typically in a TMD, so a jaw muscle, which is characterized by increased muscle tension as being one of the problems, that's actually the worst place to go. You end up with more pain. So you may gain some cognitive, but it makes their pain more recalcitrant and their dysfunction. And so then you have these patients that are constantly having to play this, well, do I want to feel like I'm like drugged and not able to function, pain. And in a TMD world, it's pretty straightforward, but it's not always that common. Patients don't come with just one flavor of pain a lot of times. So if you have, say, and a good example would be a migraine patient. So if they get chronic migraine, it's common that they'll pick up a TMD. You can think of that as like a hypersensitivity state. And so now you've got multiple overlapping pain disorders. And so what you do with one hand from a treatment may have a positive effect one way, but a negative effect on the other disorder. And it goes both ways. So sometimes let's have patients that have TMD that will be taking NSAIDs on a daily basis, and then their migraine changes from episodic to chronic flips over to medication-induced headache.
These kinds of binds that we get into with medication especially, I think are one of the underlying motivations we have for using neuromodulation in many of the disorders that we work on. And David, I'm just thinking about, Parkinson's disease, where you get side effects from using dopaminergic medications, where you have the same kind of thing. It's very difficult to achieve motor benefit and cognitive benefit at the same time. And so we end up, really struggling with that. And so it seems like, a neural circuit-based approach, as is potentially possible with neuromodulation, might be one way of trying to dissociate the, for instance, cognitive from the nociceptive systems, basically, that we end up hitting one in the right way, one in the wrong way with some of these treatments you're describing.
Well, I think for a lot of what we do, at least for the more refractory cases where it's very severe and we're doing targeted neuromodulation, we have a lot more freedom about, where we're actually making changes. But, medications, it's
Right.
pretty much you get the whole body. And so you get all, with Tegretol, you get all the side effects, or with gabapentin or with stimulants, you get all of these side effects that you have to then use other medications to fix the side effects. And then soon enough, you're going to a specialty pharmacy to compound, 7 drugs to, compensate for all these side effects. And with neuromodulation, I mean, there are other, factors that risk, surgical risks and all that kind of stuff. But that being said, there's a lot of work on the non-invasive side. I mean, your practice really hinges on doing, I would say, quasi-targeted neuromodulation with TMS, right, Alex?
Yeah, for sure.
And certainly you're not getting into the brainstem with TMS. And so, there's not a lot of anticholinergic side effects from TMS. So, there's movement in that direction. So things can be a little bit more targeted.
Mm-hmm.
One of the things that to me is really exciting as I've gotten to know your guys and your work is the concept of where neuromodulation can open up a window for plasticity and change. Because in our clinic, we're always looking for behavioral change and looking at, okay, if we can help patients with different thinking and changing, we can maybe get some of that plasticity. But we have that group of population where the patients are bought in, they're working hard, they're trying, and the plasticity is not coming along, is not commensurate with the amount of effort that they're putting in. They're just kind of hitting a roadblock. And the concept of, and use plasticity to open that window to allow greater change to happen is exceedingly exciting. And I can imagine it can be potentially both invasively and non-invasively options. So.
Yeah, and I think that's really where sort of Pandora's box is right now. Is one, how do we encourage? If someone is stuck in a state and cannot get out of it, then how do we push them out of it? And then how do we, and another way to look at it is, you want plasticity, but you don't want too much plasticity. You don't want them to just be moving around all the time. So that's one of the challenges with neuromodulation and doing trials is what's a big enough push that it's not, a merry-go-round, and I think that's something that the field has not grappled with at all. And will come with time, but sort of targeted plasticity as a product of neuromodulation, I think is really key. And I think from our perspective, the way to really dive into that is essentially a circuit-based approach. As strange as it sounds, that is the most holistic way, because the circuits that we look at are, I guess they're not as circuit-like as we, as it sounds. They're extremely broad, and oftentimes frustratingly so to measure. And but as we gain experience, instead of treating them as like pure circuits, we understand that it's it's more like tapping into a massive network. You know, we sort of focus on one side of the network or the other, but we know in many ways it's still, you know, greatly connected in ways that are challenging to measure.
I was just thinking about the plasticity question. I was thinking of an analogy. I guess too little would be like cracking the window open. The right amount would be like opening the door. The wrong amount would be like taking the side of the house off.
Right.
And it's like, how do you figure out what that level is? And I can imagine for different types of patients, that amount is different.
Mhm.
Some may only need a cracking of the window, and that's sufficient for them to get them over the hump.
Don, if resources and time were not an issue or a factor, what is like one big research question that keeps bugging you that you'd like to address or resolve in the coming few years?
So it comes from what I initiated with some observational research is I would really be able to, love to be able to characterize the patient and understand their risk factors before having dental procedures. And if you knew what those risk factors were, then you could be in the business of mitigating that risk when looking at moving forward. And so moving into that risk management type strategy, I think would be phenomenal, because then you could say, okay, is it the rumination and the negative tape on their head that they're worried about their dental care that puts them at higher risk? Then you could tailor and say, okay, do we want to use a medication trial? Do we want to use a talk therapy? Do we want to use a verbal script ahead of time to see if we can kind of decrease that before the dental care, which then have a better outcome of less chronic pain on the back end? That would be ideal. And what my research kind of shows up to date is that the majority of the risk actually comes with the patient, not the dental procedure stuff itself. On average, what you guys do as dentists and endodontists is actually so high that it's not problematic. You do such a good job across the board. It's the factors that the patients have that they walk into the clinic with outweigh any of the things that you are doing. And so knowing those and then designing ways to interact. And that's where kind of the new frontier, if you will, this goes on with what Alex's question was, is get better granularity to that access to stuff. Because it's going to be a variety of those things. And so what my research points to is catastrophizing and optimism. So catastrophizing is harmful, optimism is helpful. Those are kind of two of the biggest factors, and that is including perceived stress, it includes anxiety, that includes depression measures being there as well. So it's really the pain level catastrophizing that's driving.
Very cool. I just put you on the calendar for the same time next year. I'll ask you the same question. We'll see how far you got into. That's a really interesting question to delve into. So, thank you, Don. David, Alex, any other questions?
I think so. I mean, I got lots of questions actually, but
David?
He's sitting there thinking. I'm getting worried. I've seen that face before.
Me too. Me too. Way too often.
My grandfather was an oral surgeon, and he was stationed in London during World War II, and he operated on all these
British teeth
people, soldiers, I think mainly airmen who were injured, who shot in the face or whatever, and they flew them into London. He operated on them. And I never met him because he died like a year before I was born, but imagine he had some pretty amazing stories. But I wonder a little bit about, what happened to these guys 10, 20 years later out from their injuries, because that's the stuff you don't really hear as much about. But
yeah, and I can remember when I was really early in my career, thinking along the same lines, and I was talking with ENT surgeons that were doing these large surgeries for facial cancer, and so of course involving multiple nerves, large resections. You would expect to see a lot of chronic pain associated with it. And I talked with some of the surgeons, and they're saying, well, I really don't see that amount on patients. And I shook my head, and I'm like, really? My first thing was, are you looking?
Yeah.
It's probably not that hard. But the other aspect to it is it gets back into that optimism aspect of things. I think patients are able to reframe. Are they having some chronic pain? Yes. And they're looking at what does it mean to them? How does it interact? And with the facial cancers and surgeries, there is a level of them being able to show to the rest of the world that things aren't okay and right. Whereas some of our chronic pain patients where you can't see anything, they feel much more despair, I think, because of that, because they look and they have some levels of thought like, well, I should be okay, but I'm not. I look normal and everyone else thinks I look normal and I don't feel that way. I think they struggle at a different level, even though they're not in the same situation. So I think we as society would go, well, that you should be worse off. So it's a little paradoxical that way.
I mean, that's really interesting because what I was thinking about was, talking about these risk factors and what that really translates to and how a patient could really affect the outcome of a surgery. There's certainly, pretty well documented risks from, chronic disease related to infection. But then you start to wonder, like, so let's say you're a catastrophizer, and what's the real difference in how you end up with a bad outcome based on that risk factor? Is it, you're seeking too much care, too little care compared to the norm, wait too long, wait not long enough? And really what that boils down to is essentially the same thing that we're tremendously interested in, which is how does that state of mind or state of biology affect the process of how a decision like that gets made?
I think you're completely correct. I want to remind you that when someone's entering a study, say a root canal study like mine, and I get a measurement of high catastrophizing, there's a whole bunch that is fed into that high catastrophizing. Prior exposure to other root canals, how they view and interact with dentists or healthcare in general, memories, cultural differences, all of that is kind of key in there. And so, great, I got a measure of catastrophizing, woohoo! But it's all those antecedents that would really, and like I said, as you guys are looking at that cognitive and decision-making and value proposition aspect of things, I think would be exceedingly helpful in kind of getting to the bigger constructs that end up being measured and found to be statistically significant.
Yeah, I mean, it's really, it's not, it gets tricky here with the ethics of how we talk about this in terms of, blame. I think we should be clear. It has nothing to do with blaming a patient for, an outcome. I think it has more to do with detecting trajectories that end up with more harm. And really the decision that someone makes is part of a trajectory, like you're sort of pointing out, being a catastrophizer on the pain catastrophizing scale, is really just a cross-sectional measure at one data point in time and emphasizes certain factors. But really, nobody, nature versus nurture aside, nobody really got there, without all the things, as part of their own journey playing into that, having a terrible experience and having PTSD as a result of that experience or whatever it may be. It's really just detecting the trajectory rather than, rather than like an innate characterization of a patient.
Mm-hmm. Yeah, and I think the point that you bring up, there's no value judgment being made on a
Right.
patient. It's just like, what are the things in play, much like you would with anything else, like numbers of teeth or infections. Yeah, completely agree.
Well, that's fantastic. I think, facial pain does not get discussed enough. And it's really nice to have you talking about that, talking about this in the context of what we're typically talking about, which is essentially cognitive neuroscience, because, facial pain is one of those things that really is on the minds of patients that have it, and their families. I mean, it often leads to tremendous disability. So we're really excited we got to talk about that a little bit today, even if it's just sort of the tip of the iceberg for facial pain syndromes.
Well, this is my first time talking with you guys, and actually my first time doing a podcast like this. So I'm kind of interested in knowing, as Mohammed, you said, like a year later, I'm going to ask you, see how far you got. I'm like, a year later, I want to see, did anyone actually listen to this?
My mom,
Oh, your mom, okay.
She tells you she listens, but does she?
That's a whole nother. Alex's mom. There we go. Yeah.
She won't lie to him.
Probably not. Yeah. No,
but yeah. So I am curious to see if some of the stuff being covered is resonating with people.
Yeah, I mean, especially because we have a lot of stuff going on. I think it will be good to revisit a year from now or a couple of years from now to see where we're at and how our sort of perspectives have possibly changed, because we do have a lot of stuff going on between our labs and our clinical practice.
That's been a neat thing for me as an outsider to see, is the amount of collaboration and dialogue that is happening across different types of labs and areas of medicine, and how these intersect. So definitely revisiting some of these conversations sometime down the road would be something that we would do, just to see where these collaborations and continued dialogue is taking the work that you're doing. So
yeah, look forward to it.
Thank you so much, Don. And
yeah, thanks, Don.